see some familiar faces over there. Welcome everybody, and welcome to everybody who's online as well. So as Sue said, I'm Gemma. I'm one of the specialist preterm birth midwives at Leeds Teaching Hospitals, and myself and Lizzie Kilburn. There we go. So that's myself and Lizzie Kilburn. So Lizzie, unfortunately, couldn't be here today. It's really sad. But myself and Lizzie are part of a multidisciplinary team of staff from Leeds, along with Khalees, our dedicated maternity support worker, and Lizzie, Bonnie and Nigel Simpson, who you might have heard of. They've been quite... they're known nationally really for their work within preterm prevention, and Nigel and Lizzie both helped to write the Saving Babies' Lives document. Leeds Teaching Hospitals is a large teaching hospital with approximately 10,000 deliveries a year, so it is a large hospital. And we are a specialist tertiary referral centre for preterm prevention care across the country. So preterm birth is the most important single determinant of adverse infant outcomes with regards to survival and quality of life. 70% of stillbirths and neonatal deaths occur in babies born before term, and the NHS long-term plan is to reduce the preterm birth rate from 8% to 6% by 2025. Prematurity is the most significant cause of mortality in children under 5 and is associated with significant morbidity in surviving infants. And preterm birth is estimated to cost health services in England around £3.4 billion a year. So the iceberg analogy that you can see there, it's quite interesting. We're getting much better at saving early babies now. So, 23, 24 weekers, but even now we'll attend at 22 weeks. And although we are saving these babies, the morbidity rates and the morbidity for these children is widespread, and that obviously comes at a cost to both the families and to the NHS. In terms of national drivers, the element 5 of Saving Babies' Lives was published in 2019, and now, fresh off the press, the next Saving Babies' Lives updated version 3 was published a few months ago, and it focuses again on preterm birth. It highlights the 3 Ps of preterm birth, so prediction, prevention, and now perinatal optimisation. So in terms of prediction, we're looking at risk factors in pregnancy, making sure that we're properly risk assessing and addressing those. And then if we know about risk factors, so if we know that a lady's high risk, it's what we do to prevent the preterm birth, so things like sutures, transabdominal sutures, Shirodka sutures, using progesterone, and doing an intervention to prevent preterm birth. And then if we can't prevent the preterm birth and a lady presents, it's making sure that we're optimising the neonate to make sure that the outcomes are as good as can possibly be. So in Leeds, we had a well-established clinic that had run for about 20 years, but it lacked dedicated midwife support. So we had Lizzie and Nigel looking after these women, but the midwifery care just wasn't there, and the ladies were going back to the community midwives who were looking after them excellently. But as we know in community sometimes, particularly at the moment, the staffing's a bit, we struggle, don't we? And the continuity wasn't there often. So women were having to retell the stories, and were often back in clinic every week and things like that. So as a trust, they invested in myself and Lizzie to become the preterm specialist midwives, and we've been in post since January 2022. So actually looking at the role, so it's been a great journey in the last 18 months, and we've been given the freedom really just to look at the needs of these women and families, and look at how best we could meet the needs and how best we could care for them. And we have basically used the Saving Babies' Lives document and recommendations, and also looked at the BAPM publication, so the British Association of Perinatal Medicine, that gives a lot of guidance about caring for these women. And the work now falls into approximately 9 categories, which are highlighted on this slide. So we've set up a specialist midwife clinic. We're now providing postnatal care following a preterm birth, actually based on the neonatal unit. We review all births under 34 weeks to look at themes, to look at areas of good practice and celebrating that, but also areas where we might be able to do quality improvement. quality improvement projects, which I'll go on to talk about. We also visit maternity wards within the hospital, so we meet mums and dads who are, having planned preterm births or who are at high risk of having preterm birth. They've come in with ruptured membranes or they've had positive fibronectins, and so we visit those areas or contact them on a daily basis. We closely work with other specialist maternity teams, so teams such as maternal medicine, the twins team, the teens team, mental health team, fetal medicine as well. So we work closely with those teams. We provide staff education. We work jointly with maternity and the neonatal teams, and that's been one of the key areas really that we've worked on. The relationship, the perinatal team, we're trying to be called, I think, so that it's not just maternity and neonatal, we're one team. And then more recently, we've set up a national network of preterm midwives. And the collaboration with working between maternity and neonatal has definitely been one of the important things in the success of our team in the last 18 months. So in terms of quality improvement, in areas where we saw that care needed to be improved, we initiated these quality improvement projects. And the main projects have been the ones that are highlighted there. So we've started to provide antenatal care for people at the highest risk of preterm birth. So those women that have got Shirodka sutures or transabdominal sutures or on progesterone. So we now caseload those ladies antenatally. And we've started to provide postnatal care for the women that deliver under 34 weeks. So they're two of our main quality improvement projects in terms of maternity services. And then the third quality improvement project is one we're really proud of. That's the Immune Boost project that we've done collaboratively with the neonatal unit. And that's about improving maternal breast milk for babies born under 34 weeks in Leeds. So the Specialist Midwife Clinic, we launched in May 2022. We have 2 clinics a week, one at LGI and one at St James's. We offer hospital-based antenatal care for those at the highest risk of having a preterm birth. And the clinic runs closely with the Specialist Consultants Clinic. So we run it actually alongside the consultant clinic, so when that's ongoing. And the absolute benefit of that is that if we've got a patient that's anxious or is showing signs of preterm labour, we can quickly refer them to the consultant for review. And it also just is great it's a great MDT approach. We offer a personalised approach care to the antenatal pathway that we provide. So it's very much based on the woman's needs and her unique needs. And we discuss the symptoms of preterm birth and the importance of early access to triage or maternity assessment. So as we talked about earlier, the 3 Ps. So we talk about, if there's any signs of early labour, just emphasising that women should be seen as soon as possible so that we can ensure that that baby is optimised for delivery. And we also speak quite a lot about expressing breast milk, which I'll go on to talk about in a few minutes. The last thing that on that slide is just there about the close links with the perinatal mental health team. So this has been really important for us, and we've really learned quite a lot about the ladies that we're caring for, in that they often have significant, raised anxiety because of the previous loss, previous preterm deliveries, late miscarriages, neonatal deaths, and they are a very special group of women that need a lot of support and care. And so often we do feel that we need to refer them to the perinatal services because of their anxiety, and sometimes that they're still even grieving. So we work closely as a team. These ladies often are reluctant to access antenatal education. They feel quite isolated from other mothers, want to protect and not even think about actually taking a baby home. So it does take a lot of TLC looking after them. So looking at the actual pathways that we use within our clinic, because like we say that a lot of these ladies have had children before, whether they've survived or not, they are multips. So in community, they're often put on a multip pathway. Some community midwives are, absolutely brilliant, and they put them on the primate pathways just to give a little bit more contact. But we were finding a lot of the ladies were on a 16 to, they had a big gap between 16 and 28 weeks where they had minimal midwife contact, and that's often the time where they have had losses or delivered early. So we adapted the pathway that we use, and we use an enhanced preterm pathway. So we have 2 extra contacts. So obviously, 25 week would be a primate contact, but we also see at 20 weeks as a minimum. We also try to see around the time that a lady would have had a preterm birth before or a miscarriage, and sometimes these women, we need to see them weekly. So the benefit, and we're very time rich, and we know it's a luxury, but some of these women we can see every week, and we have longer appointments with them just to try and support them as well as we can. And so, as a minimum, we would see them as a bottom kind of enhanced pathway. So just as a bit of a case study, really, just to highlight kind of what we do. A lady that we looked after last year into this year, is a 38-year-old lady with an IVF pregnancy, and unfortunately in 2020 she had a 19-week spontaneous loss. So she was referred to preterm clinic as per Saving Babies' Lives guideline and Trust guideline. She had a new pregnancy in 2022. She was seen in preterm clinic at 12 weeks to discuss her plan of care for her pregnancy, and she opted for an elective Shirodka suture, which was inserted at 13 weeks. She had a personalised approach to care within clinic. She had really high levels of anxiety during her pregnancy, understandably, and she was seen weekly by our consultants and preterm midwife between 16 and 21 weeks due to her anxiety around the time of the previous birth. We chatted to her about kind of supporting her mental health and how she felt like things were going, and we offered her a referral to perinatal mental health services, which she accepted. She was then seen weekly for scans, and this is often what happens. So after 24 weeks, when kind of the pressure isn't on the cervix as much, the consultants then back off a little bit and do abdominal scans and don't need to see our women as much. So then they often feel a bit like they've not had, that intensive support, and then we take our hands off. So we continued to see her 2 weekly, so she had regular contact with either the consultant or ourselves. And at 34 weeks, we actually had a joint appointment with the perinatal mental health midwife. So in Leeds, we're really fortunate that we actually have a perinatal mental health midwife. So we did a joint contact together, because obviously she would be looking after her postnatally on an enhanced pathway as well. And at 39 weeks, she had a lovely delivery, nice delivery, and she had a lovely baby boy. And she was discharged home on day 1 from hospital with postnatal support from the perinatal mental health midwife that she'd met during her pregnancy. So it was a lovely experience for her and for us that we could do that for her. And this is just a picture of some of our patients that we've looked after, all with consent. They signed consent forms for us to share. So it's quite emotional looking at those pictures, because you feel like you've really been on a journey with these families. And all these ladies had either had a preterm birth or lost babies before. So when we set up new services, it's always really important just to get that feedback about how the service is going, so that, again, we can inform practice and make changes if needs be. So we've worked quite closely with the maternity and neonatal voice partnership, but also with the patients. And at 34 weeks, we actually provide a questionnaire to our patients just to get some feedback. And we were just so proud that 100% of the women thought that their care was either personalised or personalised to them. 100% of them said that they thought they'd received enough face-to-face contact, and they rated the care as very good, which was actually the highest category. So I'll just read one of those, really, because it's Lizzie was going to read some, I was going to read some, but I'll just read one. So after having previously lost a baby, the preterm midwives gave me extra support that was personalised to me and my unique situation. I feel like they did everything they possibly could to ensure a better outcome, and were happy to give me all the time that I needed when we attended appointments. I felt that they genuinely cared and went above and beyond to look after us. I felt that they were fully invested in us personally and never made us feel like another number on a patient list. They made a difficult time a lot easier, and I cannot thank them enough. So it's just lovely feedback, really. So then just looking at the kind of the postnatal care, so this is something that we've launched in the last month or so, and it's something that is we're just learning as we go along. But BAPM, who's the Perinatal Medicine Association, highlights that immediately after a preterm birth, mothers may feel traumatised, frightened, exhausted, unwell, and isolated from family support systems. And a local audit that we did as a benchmark in Leeds we found that ladies that delivered under 34 weeks showed fragmented and sporadic care, often seeing a different midwife at each contact. So at Leeds, that when we're doing outpatient postnatal care for the ladies that deliver preterm, they come back to the postnatal wards or the antenatal ward, often having to leave the babies on neonatal unit, sometimes very sick babies, to sometimes sit and wait on the ward for quite, on a busy ward, waiting to be checked. And we found that sometimes, sadly, if women didn't turn up, they were not sometimes followed up, and they weren't transferred to the health visitor and things like that. So we just wanted to standardise that approach to postnatal care for these women. So by doing the postnatal care in Leeds, what we do is we actually work from neonatal unit. So neonatal unit have welcomed us with open arms, really, to help support these families. It provides continuity in the postnatal period. We can look after them for a little bit longer than 10 days based on the need of the families. It provides a flexible and personalised approach to care. Again, we have the increased time that we can spend with them, but they can also have increased time with their babies, so it fits with family integrated care, so they're not having to leave the baby's cot side. It helps us to have an overview of the patient's emotional needs and offer timely referral to mental health support or the neonatal unit psychologist if necessary. And we again can support with expressing and breastfeed their preterm baby, so we work with the infant feeding lead from neonatal units to provide that support as well. Another thing that it enables us to do is provide an opportunity for a timely postnatal debrief. So we have a debrief service within Leeds, but there's a little bit of a waiting list. And sometimes these women just need that debrief a bit sooner, so we can sit down and look at the notes and just unpick things and piece things together, because often these families are quite traumatised from what's happened. And the other important thing, it's not on that slide, but the another thing that we can do is offer some preconceptual advice for next pregnancy. So in terms of reducing the rate of preterm birth from 8% to 6%, by what we're doing initially in antenatal, it's probably not really affecting that, but the preconceptual side of things is a massive thing for us. So making sure that if women are planning to go on and have another child, that they're in optimal health, so that they're not smoking, they're appropriately screened for STIs, and that they're fit and well for the next pregnancy. So the other quality improvement project that we've worked on is the Immune Boost project. This is a joint maternity and neonatal quality improvement project, which aims to implement the BAPM toolkit for early breast milk. The aim is to increase the proportion of babies born in Leeds who receive colostrum within the first 24 hours of birth, and when they're born under 34 weeks gestation. So what we know about early maternal breast milk, if it's given within the first 24 hours, we know that it reduces the risk of necrotizing enterocolitis by 60%. It reduces the length of stay in hospital and sepsis for these early vulnerable babies. So what we've done is we've produced a video for parents to access at any time of day. So it's a YouTube clip. It's ourselves, myself and Lizzie, and one of the neonatal doctors, about preparing for an early baby, the importance of breast milk, and within we've created some immune boost packs. So if women come into hospital, they come to maternity assessment and the waters are broken or they're in labour, they get a pack with the QR code, syringes for expressing, bonding squares, leaflets about immune boost, so they get the whole package. We created a logo which is used between maternity and neonatal units, so it really gives a joint approach. It helps to motivate staff and remind staff, and also for the women and the families, they can see that it's a coordinated approach between ourselves and neonatal unit. And just to show you the kind of success of this project, so this time last year, as the baseline data shows there, within the first 24 hours of life, about 30% of babies were having expressed breast milk within the first 24 hours. And through kind of the initiatives we've put in place, as you can see in April, about 95% of babies had expressed breast milk within 24 hours, with 100% of women actually expressing. So it's been massively successful. So the difference in lines is really because, even though we're supporting women to express, we don't always get milk. So the main thing is that a woman's starting to express. But what we've started to do now is to put women ask the women if they want to go on the double pumps when the baby's first born, and that's increasing the yield. So that's another improvement that's been made just this last month. Another area of work that we're involved in is maternity ward visits and collaborative working. As I mentioned earlier, the collaboration across maternity and neonatal services is essential when looking after these families. And what we try and do is go onto the wards to see women who are having a planned preterm birth. We take referrals from fetal medicine, maternal medicine and the multiples team. So obviously these teams are the teams that are planning deliveries a little bit early, so we get involved and work closely with them. Whilst we're on the wards, we ensure that antenatal optimisation is in place, so that, making sure that women have had the steroids if they need them, and just liaising with our consultants if we need to. And we also discuss the benefits of early maternal breast milk. We offer emotional support and answer any questions that the families might have. Often they've been seen on ward round, they're getting given a lot of information, and then they're left to just overthink things. We coordinate the neonatal antenatal counselling if it's not already completed. So if we know that a lady's having a planned preterm birth, that's not being done, we just contact neonates. And these women are the women that we'll often be caring for postnatally. So it's nice to meet them antenatally. And sometimes we actually go on to delivery suite and help them express the breast milk and provide support there too. It's also an opportunity for staff education. So just being there, just being amongst the staff is been great. Our matron encouraged us to do that, and it's probably been the best thing that we could have done. Rather than pinging emails and things like that, it's just been great to be visible. So just continuing with staff education, I think when I started this role, I don't think I realised how much I didn't know about preterm birth, even being a midwife for 20 years. So Lizzie and myself really wanted to share what we'd learned and to communicate that to staff. So we have started to present at large staff education sessions. So we do there's a Friday teaching at Leeds, and we try and get involved in that if we can. We've met with individual community teams within Leeds just to try and tailor information that they might need to know in terms of their caring community. We provide staff newsletters on different topics around preterm birth. You can see a few of those on there. So like the impact of kind of LETS procedures and comb procedures, impact of caesarean section at full dilatation. I wasn't aware of the impact and that increase in the risk of preterm labour. And then just regular newsletters just about what we're doing. And then, hot off the press, is the National Network of Preterm Midwives. So in the last year, we'd set up a group of preterm birth midwives across the country, because it is quite a new role, so you might have seen it popping up within your own trusts, the adverts coming out on the back of the Saving Babies Lives document. And because it's a new role, we just thought it'd be a really good idea to support each other nationally and to kind of share resources that we'd put together. It's now grown, so it's now representing over 30 trusts nationally, and in the last few weeks we actually went on to the NHS Networks platform and officially set up a group on there, and it's just growing and growing every day. It's a great way to share information, and every day there's messages coming through in new members. So if there are any midwives within your trust that are working in this area, I'd definitely encourage them to join. So we try and meet on Teams every 4 to 6 weeks just to get together and have a chat as well. So it has been really good support. So that's the end of the presentation. If there's any questions, I'm happy to take questions.